All right, well, thank you for inviting me here today. And those were great. The first two talks were great, and the talk to follow me is great. And then I looked at my talk, and you look, new medications and side effects. How much fun could that be? And here I am to be the bad guy. And I realized that I was going to try to take a different approach on this, to try to do it in a way that we could be aware of some of the side effects of these new medicines, but kind of look at the big picture. And I think that both, I think the great transition here, as what Dr. Matter was talking about, is the importance of integrating your clinical care, of your clinical care team. And some of the slides that he used, I'm going to be using at the end, because I think that's the important take-home effect. The other thing with Dr. Gatos here is the exciting clinical research and some of these new medications that are coming out, and really going forward with this precision medicine, and realizing that each of you is an individual. And my partner, Dr. Wysocki, will be speaking about more specifically about precision medicine afterwards. So I thought that the best way would be to look at a perspective. I just look back on my life and realize how many years I've been involved in this and doing this, going back to what it was like to take care of an inflammatory bowel disease patient when I was at medical school, Mount Sinai, in the mid-'80s. And I'm going to take you from there to where we are now, and integrating some of these newer medications and discussing some of those side effects, and then really bringing it back to you and trying to figure out how to go forward, whether it's clinical trials, precision medicine, or integrating with your team to kind of move forward. The three medicines that I'm going to focus on when it comes to new medicines in the end is, I think it's exciting to talk about ustekinumab, stelera. Although it was approved 6 years ago in 2016, I think Dr. Gatos really speaks about not only this medication, but some of the more specific medications that are going to be coming out hopefully within the next 4 to 6 weeks. So I think it's a good idea to take a little bit of a look at that. Ozanimod Zeposia, approved last year, 2021. Actually, right on my 60th birthday. I remember that as an exciting, another revolutionary breakthrough in the way we have a new mechanism of action to take care of our patients. And then finally, just approved in March, March 16th, I believe, on my son's birthday. So that's how I remember these days. Is rinvoke, which is a more selective JAK inhibitor. And I know Dr. Gatos talked about the mechanism of that. And the question is, what we're really hoping, and the goal here, is that these medicines can be more effective and have less side effects in the end. But the question is, how best to use these medicines, and who's going to be the right candidates. So just in general, the general approach here is that even in going back and looking at Crohn's disease and ulcerative colitis in general, remember, the goal is we want to treat this disease, and in understanding the difference between Crohn's disease and ulcerative colitis. Crohn's disease can involve any area of the intestine, and it has these complications with fistulas, abscesses, strictures. Ulcerative colitis is always in a continuous fashion, either mild, moderate to severe. So trying to make our choice in the medications is important. And what is the goals? The treatment goals is really to take a patient and induce remission, maintain that remission, disease monitoring and prevention. We want to monitor the disease and prevent relapse, and really, ultimately, it comes down to improving your quality of life. Now, how do we control inflammatory bowel disease? And what is inflammatory bowel disease? Well, we know it's a chronic inflammation of the intestine, but it's not one disease. And we're trying to understand the factors that cause the disease to occur, the factors that cause the disease to go into remission, and the factors that cause the disease to relapse. And we're beginning to understand, and Dr. Wysocki will get into this a little bit more in detail when we talk about precision medicine, is that we begin to understand that there are patient factors that are involved here, there's the disease factors, and there are therapy factors. And this is why any one patient is an individual, depending on whether these factors are present. So what do we know about prescription medicine? Going back to the mid-'80s when I was in medical school, well, what did we have? Well, we had antibiotics, and the benefits of antibiotics were great in pouchitis and fistulas and abscess, And even in inflammatory Crohn's disease, we used to use this as a way of treating Crohn's disease. However, not very useful in ulcerative colitis. And as you know, the potential side effects of these medications, resistance, infections, side effects from the medication, and the dreaded C. diff, which we've been seeing more and more of. Aminosalicylates, the 5-ASA, mesalamine products, very, very helpful drug. This very helpful, especially when it came down to ulcerative colitis. These drugs are very well tolerated, especially if you had mild to moderate ulcerative colitis. We would try to direct the therapy to that part of the intestine that was involved. We know with ulcerative colitis, it's a continuous inflammation. So whether it was a suppository, or whether it was an enema, or whether it were oral agents to direct the medication into this area to control the inflammation, that was very, very helpful. The side effect profile of these medications were pretty limited. Very, very few serious side effects. I mean, anyone can have a hypersensitivity reaction to an agent. However, the side effect profile was pretty safe. Your recommendation to follow kidney tests on an annual basis just to make sure there are no issues that occur, but the tolerance was really real great. Now, back in the mid-'80s, one of the best drugs that we had in sort of the mainstream way of taking care of this inflammation is the corticosteroid. The corticosteroid, think of it as the shotgun way of controlling inflammation. Dr. Geddes and some of the clinical studies are talking about being much, much more directed on how we treat inflammation. This is the shotgun approach. And if you wanted to control moderate to severe Crohn's disease and ulcerative colitis, and many of you know, steroids do work. Now, I say that, but when we talk about some of the side effects of the newer medication, you look at the side effect profile of steroids. The prednisone side effect profile is huge. There wouldn't have been enough bullets to kind of include here. But when you look at it, it's infection, mood swings, neurological changes, the physical appearance, weight gain, skin fragility, growth delays, bone loss, osteoporosis. The tapers that are often patients are put on are much too long. So although this was really considered the big rescue medication in the mid-'80s, the side effect profile was really tremendous. So the thought back then was to try to begin to think about ways of avoiding steroids. This is the key to therapy. Avoiding steroids and directing and figuring out how to spare these steroid agents and direct the care of inflammation in a more specific way. So the immunomodulators, this especially goes back to my Mount Sinai days, the azathioprine and the Imuran and the 6-MP, were really not approved for the treatment of inflammatory bowel disease. However, many in the New York region and around the country began to use these medications with the goal of getting patients off of the steroids. And it actually worked pretty good. Once you can get remission, it kept people off about 70% of the time to stay in remission for at least a year. Now, that was great because it avoided the side effects of steroids. However, when it came to the risk profile of these immunomodulating agents, there is a definite risk with them. The risk it can be mitigated by checking to make sure you have the genotype that allows you to metabolize the drug. But however, there are early reactions with fevers, infections, pancreatitis, low white blood count, elevated liver function tests, and dreaded lymphomas and some skin cancers that can occur. And that's why anyone who's been on these medications do need to be monitored by a dermatologist on a period basis. So this brings us into the mid-'80s, 1984. Thinking, it's hard to believe that that's 38 years ago. I can't believe how long it's been. It's kind of a weird perspective looking back on life that way. So I kind of brought it down a little bit into the Academy Awards. This was the Academy Award winning best movie, Terms of Endearment. So you have to think, back then, I'm in medical school, 1984 at Mount Sinai, a great new drug was approved called Azicol, mesalamine. This is all we had. We had antibiotics, we had sulfidine, prednisone, azathioprine, 6-MP, and then Azicol came in. We always did have the surgeons that were ready to operate because it is at times a therapy that can be offered to patient. But this is all that was available in 1984. And it really wasn't until 14 years later that really a titanic shift in the way we take care of our patients with IBD occurred. Interesting enough, that was actually the best movie that year, and it's when infliximab for Crohn's disease was approved. Now, this was a revolutionary change in the way we took care of these patients. That list was pretty short, what I showed you earlier. When it comes to the biological therapies, this is a whole new world that was looking at taking care of patients. These drugs are made from living organisms. They're made from cell cultures, and their products, their proteins and genetics are kind of produced in a way that goes from a petri dish in a subterranean lab somewhere in Pennsylvania to these giant, almost beer vat looking facilities where it's mass produced. So there are some differences. And the risk of these medications are infections, infusion or injection site reactions, psoriasis-like reactions. So there are definitely potential risks, but we begin to understand that these risks, as we become comfortable in using these medications, are much, much lower, especially if we screen for tuberculosis, screen for hepatitis B, and really follow these patients closely. The way these medications work, especially the anti-TNF class, instead of the shotgun approach that steroids are used, when the inflammatory process occurs through the activation of this tumor necrosis factor, these medications come and mop up the tumor necrosis factor, their anti-tumor necrosis factor drugs, to kind of help with the inflammation. So again, more specific than steroids, but much less specific than some of the other agents. Now, I also chose to focus on stelera, not that it's a new medication, but as Dr. Gatto says, this is much more specific than the infliximab and adalimumab and the anti-TNF medications. These medications specifically block this IL-12 and 23 receptor through the P40 pathway. And by specifically blocking it, you can actually help with the inflammatory process, a little bit earlier on in the process. And the way this drug is administered, because when we look at all of these drugs, we need to think about adherence and how easy it is to administer. It's one intravenous injection, and then every 8 weeks an injection. Now, the risk of these medicines, the idea is, as you get more specific, we hope that the risks become a little bit more limited. I mean, there's still the risk of infections and TB reactivation, and always concerned about administering live vaccines. And that's why anyone on a biologic medicine needs to make sure they communicate with their healthcare team, not only their GI team, but also their primary team, to make sure live vaccines are not administered. Recently, only a few years ago, in 2018, a new class of medicines with a mechanism of action was approved for inflammatory bowel disease. And these are what are called targeted synthetic small molecules. Now, the cool thing about these types of medications is they are broken down in the GI tract after ingestion and are directly absorbed into the bloodstream through the intestines. These are oral medications. And as far as adherence go, there's good and bad to this, because as an oral medication, it makes it very convenient for the patient, but it's very, very important that if you go on an oral medication, that the follow-up with your healthcare team is very close to make sure some of the marks are being met. The first drug that was approved for this was in 2018, tocilizumab, Xeljanz. This was a non-selective molecule that was approved, and it was a JAK inhibitor, and it was a non-selective JAK inhibitor. Ozanimod was approved again last year in the trade name Zeposia, and both of these agents were moderate to severe ulcerative colitis. Now, the benefits of these medications are they're oral and very, very fast onset of action. The side effect profile in general, and we'll talk a little bit specifically about Zeposia in a minute, is nausea, headache, upper respiratory tract infections, nasopharyngitis, and this risk of shingles or zosta, which is preventable by a vaccine that is now inactivated. Now, Xeljanz, we'll talk about that in a second, but specifically with these smaller molecules, the really pregnancy category is really not a science. So pregnancy should not be considered during the period of time. Now, one of the concerns about Xeljanz and the non-selective nature was this increased risk of blood clots and viral infections. It was the blood clots and the cardiac issues that were a concern with the class of non-specific JAK inhibitors. Ozanimod, Zeposia, in the package insert, it talks about increased risk of heart blocks and arrhythmias, and are not recommended for patients who have severe inflammation of the eye, macular edema, recent cardiac or stroke issues. And what this is doing is Zeposia is in the class. It's a more selective S1 P5 selective agonist, and as being more selective, theoretically, we believe that the side effect profile should be better than some of the non-selective agents in the past. However, it's with caution that it's real important that patients with diabetes or eye issues have their eye evaluated. A baseline EKG is recommended to perform because although when you look specifically at the studies of Zeposia, the cardiac effect on slowing the heart rate really didn't occur very much. It's just in the spirit of caution that should be done and recommended. Also, the important thing with these class of medications is knowing the situation when it comes to shingles and varicella. It's very important before starting this agent that you have documented that you had chickenpox when you were young, and if that's not documented, that you have an antibody level suggesting that you had exposure to chickenpox, and then if needed, then the zosta vaccine, could be administered. So specific, also with Zeposia, it works very, very quickly, and that's the advantage. By 2 weeks, it's oral. By 2 weeks, you may see some advantages of it occurring. Also, the reactions that might occur in the past about going on a drug and off a drug, which can't really be done well with a biologic, there does not seem to be a problem with some of these oral agents. These medications can be used before an anti-TNF, so potentially they could be a first-line drug in the treatment of moderate to severe ulcerative colitis. The risk factors very, very similar to many of the other risk factors I mentioned. The only things that are followed are the liver function tests have been shown to be elevated. However, when seen, they're reversible greater than 95% of the time. Slow heart rate, macular edema, that's why we want to make sure patients with diabetes or any eye issues, uveitis, get looked at, and this risk of shingles and zosta reactivation, and that's why it's kind of important to do that. The final drug to talk about is Rinvoke, which was just approved again in March of this year. Again, this is a more selective JAK inhibitor. It's not totally selective, it's more selective. It focuses more on the JAK1 and 2 more than the JAK3 and 4. Zeposia tofacitinib was non-specific. So therefore, the thinking is as you get more specific, theoretically, the side effects could be low. However, we can't prove it, and it's going to take time to really look at this. It's contraindicated in pregnancy, and it is an oral agent that also works very quickly. Within 2 weeks, you're going to notice it. The important thing, though, to realize is that this medication cannot be used as a first-line drug, and the recommendation is to use it after an anti-TNF. So that's very, very important. The risk, nausea, headaches, upper respiratory infection, these are all the same. And then this concern, if you're over the age of 50, the possibility, and if you have more than one cardiac risk factor, the possibility of blood clots and cardiac adverse effects. And the reason that this warning is here, it's a class warning, because going back to tocilizumab, which is non-specific, the warning is there. That medication has been used in rheumatoid arthritis, and many patients are over the age of 50, and therefore some of the signal was seen there. So this needs to be monitored over a matter of time, and just drug, although there have been studies that have been out there for a while, has been out for a period of time, has been a little bit newer, and we need to kind of look at that. So I see I'm running out of time, so I'm going to just quickly get through the end here. And most of this actually kind of goes back to what Dr. Mather was talking about, and leading up into what Dr. Wysocki is going to do next, and we'll talk about this more in the questions and answer section, is although I'm talking about risk of therapy, we also need to understand the risk of no therapy, and that's really important. And we know that the risk of no therapy is related to where the disease is, the location, how old you are, the type of diagnosis, male, female, prior treatment response, allergies, intolerance, smoking history, and medication. There are models out there that are beginning to be able to predict who is going to be more at risk for more severe disease and who isn't, and how we can sort that out. So what are the evolving strategies? And this was mentioned also, is that we need to be more individualized in how we identify the disease and predict the disease. We need to develop these decision aids that the foundation has available to you to really figure out what is the right titration of therapy used, how do you monitor these people, how do you adjust it, and eventually some at-home monitoring in real-time control might become a possibility. So where are we now? We take it to 2022, and so much has happened since Titanic in 1998. Academy Awards this year, I don't know if it's going to be remembered for Best Picture or what happened at the Academy Awards, but but this is now the menu of medications that are available. And this, you can see, is overwhelming. And each of these medications have efficacy, safety, and concerns. And the question is, how do you handle this? You have to take control of this as a patient, to be an advocate in seeing your care team and going in with that discussion. Adherence is complex. It's multifactorial. There are many ways that patients are either going to adhere to these medications or not. We talked about some of the material that is available here at the Crohn's and Colitis Foundation. I think that's really important. The importance of how to engage with your care team was discussed. The most important thing, I would believe, is in seeing your care team is really identifying what is the most important thing to you. These are some of the other things that are available. So I think that the final slide really speaks about, that treatment option list, you can see from 1984 to 2022 has changed astronomically and dramatically. And it's becoming very, very complex, taking care of patients with inflammatory bowel disease. But I think it's these 4 final points that are the take-home points to really remember. One is you have to understand your diagnosis and your prognosis. And whether that can be done by some of the material that we have here through the foundation or not, you need to understand where you are when you approach your provider. Know what the goals of your personal treatment strategy is. What are your goals? What do you want to accomplish? And communicate to your GI provider. But then they're going to let you know, and you're going to find out in a few minutes when Dr. Wysocki speaks, that although it is probably very important for you to control your symptoms and improve your quality of life, what's also important is the underlying disease process that is creeping underneath the surface that's occurring. And your provider is going to want to be able to treat some of those inflammatory components to try to heal the inflammation that's going on in your intestines. And that's the most important thing. And it's participating with your care team in the shared decision-making process. Thank you.